So, Masa, Lana, and Mary and I were discussing possible didactics last week. And as we are trying to promote social distancing and limit patients coming into clinics, this was one thought that came up, how we could perhaps perform vision assessments from a distance. So I'll tell you what I found, and we can see if it's helpful. And I would love to hear people's own experiences or thoughts or ideas or strategies that they have come up with. So the usual, let me just do, sorry, I should have been ready with this. All right. Sorry, here we go. The usual. All right, first up, here are objectives: to recognize ophthalmologic adverse effects of TB medications to target monitoring strategies in patients, identify ways to remotely assess visual baseline and changes in patients taking TB medication to monitor safety, as well as to demonstrate use of remote visual acuity tools to fill monitoring needs related to TB treatment for patients while observing social distancing. So what is the need? As everyone here knows, because everyone is quite experienced with TB medications, there are adverse effects, AEs, associated with tuberculosis medications. The ones that are noted to have ophthalmic toxicity include ethambutol, linezolid, ethionamide, isoniazid, and rifabutin. So first up, people are probably most familiar with ethambutol. It causes a well-recognized optic neuropathy. This especially is true in patients who are receiving high dose, so greater than 25 milligrams per kilogram of ideal body weight. That's outside of the pediatric population, which is typically well tolerated, and/or those who are receiving longer courses of ethambutol. And typically, for most patients with drug-susceptible TB, we are not exposing them to ethambutol for more than 8 weeks. But there are patients who have drug-resistant TB who don't tolerate their other medications that are on ethambutol for longer periods of time. What's the frequency of optic neuropathy in those patients? So a systematic review, and you can see the reference down at the bottom of the screen by Ezer, looked at this question in 2013 and found that patients who were on, so looking at just those patients who were on ethambutol for 2 months and longer, found that the incidence of optic neuropathy was about 23 per 1,000. To put that in a percentile terms, that's about 2.3%. So I would say not uncommon. How common is permanent impairment? Because if you don't recognize that someone is experiencing this type of adverse effect and you continue the ethambutol, patients can have permanent impacts on their vision. So the frequency of that was about 2.3 per 1,000, or 0.23%. Again, uncommon, maybe even rare, but it does happen. What do we expect to see in those who have optic neuropathy? Well, in over 60%, the most common occurrence is a change in visual acuity. And this can be anything from a minor change. You can play a blurriness, a patient going from 20/20 vision to 20/20 or 20/25 vision, all the way to legal blindness. That's followed by loss of red-green color discrimination or acquired color blindness. Again, this is something that we commonly think of asking for, and usually we monitor with something called the Ishihara color test. But ethambutol can also cause loss of areas of visual fields or cuts in visual fields, so that a patient might say that in the middle of my, in the middle of my vision, I can't see anything, or to the side of my vision, I can't see anything. This is the sort of thing that can happen in patients that have had a stroke. And it's called a scotoma. Now, the most common one in ethambutol-related optic neuropathy is a central scotoma, where they lose vision in the center of their eye. The average time to visual impairment is about 5 months plus or minus 2 months. So let's say from 3 to 7 months, although there is a range of from 1 to 8 months. It may be a permanent, as I've said, and this can be very scary. The single patient I've had who has developed optic neuropathy from ethambutol, in which he did go on, he could not read anything after, by the time that we had stopped his medications. The time to resolution is quite prolonged. So you're sitting there hoping, oh my gosh, I hope I didn't permanently make my patient blind. Fortunately, his vision recovered, but it took about 2 months. And as you can see here, the time to recovery is 3.3 plus or minus 4 months. So be patient, and you can still reassure the patient that I think things will get better. Other medications that cause an sort of the ophthalmic toxicity, in particular optic neuropathy, include linezolid, which people typically know to assess for, and the recommendations are, like ethambutol, to perform monthly surveillance of a patient's visual acuity and color discrimination. But it's a little less well known that both isoniazid and ethionamide can cause an optic neuropathy. And while I don't think it's necessary, and we don't perform monthly visual assessment on patients on these drugs, sort of sound patient education in advance. If these things happen to you, let me know and stop taking your medications, is definitely indicated. Rifabutin, which is used less often and is more commonly used in patients who are on medications that interact with rifampin, and when, with older classes of antiretrovirals for HIV, this was an issue. But for instance, if your patient is on anti-seizure medications or on warfarin, you may choose to put them on rifabutin, can cause a uveitis, especially in doses greater than 300 milligrams per day. And how does this present? It presents as an erythematous, a red, painful eye, and blurring of vision. So what's recommended and what do you all do out there? Get baseline visual acuity and color discrimination. For those on ethambutol and or linezolid, perform monthly screens of visual acuity and color discrimination. Diabetes control, and why is this here? Because someone who has poorly controlled diabetes can frequently, and that is, what I mean by that is that their blood sugars are frequently high, greater than 250, greater than 300. They will not infrequently complain of changes in their visual acuity, particularly blurriness. And if you have that patient, it can be difficult to sort out what's going on. The patient that I mentioned, that I that was legally blind until 2 months after stopping the ethambutol, he was a patient that also had poorly controlled diabetes, and that I think was part of the issue in us perhaps not stopping his ethambutol as soon as we should have. You want to educate your patients about changes in visual acuity, color discrimination. Don't forget the changes in visual fields. If you become blind in the middle of your visual field, you need to call me. Erythema and eye pain. And if the above visual changes occur, stop medications. Tell your patient if it's Friday evening, stop your medications. But now, in this current era of social distancing, and we don't know how long it's going to go on, how are we going to promote best practices in our patients? And if you have any tips from the Echo Land, I want you to share them with us. We can wait till the end of this didactic, but please, share them so that we can all learn from them. In preparation for this talk, I did a quick review of options that are out there. So this is by no means a systematic review, a thorough literature review. It's just what I did over the course of 2 days. Primarily, I was looking for app-based devices, because most of our patients will have a smartphone. There are many apps available, but most are not right for our current needs. And in truth, validation is lacking. And anytime we use a test in medicine, we want to ask, has it been validated? And for most of them, it has not. So take this with a grain of salt. Color discrimination testing. So using Ishihara color plates. So this was developed by Dr. Shinobu Ishihara, who was at the University of Tokyo in 1917. You see an example of one of those plates up in the top right corner. What they're designed to is to identify patients have problems with red, green, or other color discrimination. using a series of plates, some of which will show numbers only if you have normal color vision, some of which will show something else if you have abnormal color vision, and some of which will show nothing. There's many different online tests and apps. And in fact, when I went there, the one that came up most commonly was EnChroma, as well as a color blindness app. And if you go through them, and most of us, and I'm not colorblind, you know, they seem to work fine because they told me that my vision was normal. But if you answer the questions incorrectly, and I didn't know how to like fake it as if I was colorblind, I just randomly answered some incorrectly. They either crash or they state that you have a problem with your color vision without additional info and say to go see an ophthalmologist. And or they don't identify the specific place that you got wrong that we'd like to know. That's what we're usually able to do when we perform it in the office. What is a simple option? Well, you could email the patient a PDF with the color plates and have the patient go through them with you, for instance, on the phone. And you can sort of and go through and mark the ones that are incorrect or not. An example of PDFs of these plates, one of which has the answers, one of which does not, was sent out as part of today's ECHO announcement. And as for the plates, you can see that sometimes we ask the patient to trace the plates with the lines with their fingers. Obviously, this is going to be something difficult to do remotely. So this is my own sort of equivalent of you know, the Yelp stamp of approval. This is David Horn's stamp of approval. This smiley face, the Ishihara color blindness app. So here you can see it's available, and is it available? I'm not sure if it's available on an iPhone. I have an Android-based device. Someone could look into that and let us know. That would be a wonderful thing to do. It is free. There's a lot of color blindness apps. So when you look at it, it's by Soft Info Systems. It has this iris right here. This is the one I'm talking about. What does it do? So you can see here, the first screen, the full Ishihara color test has 38 plates. You can do a reduced plate, a test of 24 plates. It's a very simple app. It doesn't have a lot of options. You choose 24 or the full test. The patient chooses that and would go through it, okay? This is the patient can download this to their phone. You can talk them through it, and they go through the plates. And so for each different plate, they have choices to answer. Do you see a 2? Do you see a 12? Do you see nothing? Has a nice little instruction above the plate as well. Who could it be difficult for? Those whose English is not their native language, in which case you can still use an interpreter, or perhaps even without them, if they have some level of English ability, explain this. Just choose the number that they're seeing at the bottom of their screen and explain to them that this says nothing. Might be a little bit harder, in which case you might need a phone-based telephonic interpreter to explain this. Obviously, if they were in the office, they would trace this line out. We can't do that. So instead, it asks them what they are seeing. Are you seeing a red circle, a green circle, an orange line? I don't know if someone is colorblind, if actually this looks like a red circle. It would be nice to figure out. But I would choose an orange line. And then at the end of the test, this is what you get. The number correct, those that were wrong, all right? The specific plates that are wrong, they can read that back to you. Or if you're doing it over FaceTime, or if you're doing over a DOT method and they have a screen, just have them hold it up to the screen. You have a couple of descriptions here. This is maybe more information than you need, but what this means basically is protanopia, which may be a term I learned in medical school, but I don't remember it, means reduced sensitivity to red light. Deuteranopia means reduced sensitivity to green light. That's actually the most common form of color blindness. This is not from that device, but what you can see here is from a website. If someone has protanopia, reduced sensitivity to red light, this is what this would look like to them. as an aside, while doing this research, there's a number of cool applications for people who are colorblind that apparently they can hold up an image, their phone to an image, and I don't know how it does it, but it shows them what it should look like. You can also use those same apps for people who are not colorblind so that they can appreciate what something looks like for those who are colorblind. Okay, so next up, Visual Acuity. So that one, your patient can just download it to his or her phone, do it all themselves, read you the results, show you the results, and you're done. It doesn't take any assistance from anyone. So colorblindness is easy. Visual acuity, still possible, but it takes someone to help them with it, as far as I could find. If people have other solutions, please email us and let us know. When it comes to visual acuity, there are many apps available for both Android and iPhone platforms. It seems, however, that many of these apps were designed for commercial purposes. There's one, in fact, that they were trying to get FDA approval for so that you could test your vision and order your glasses just using a web-based app. The problem with these apps is that they then, if you have anything less than 20/20 vision, will direct you to their website and say your vision is not perfect, but not tell you what it is. And that's not useful to us. For other apps in which maybe it's based on the phone, it really is, and there's been a couple of systematic reviews that looked at this, it's really hard to standardize the size of the phone and the font and the required distance from the patient in order to get a valid exam. And again, there's that issue of lack of validation. Has this been retested against a gold standard in different situations to show that it actually functions well, that there's high fidelity? So I could not find an appropriate mobile-based app. When I say appropriate, one that tells us what the patient's visual acuity is that could be used without assistance. So like a paper or like a hard printout or like a PDF of the Ishihara color test, we could consider using a paper Snellen chart. And in fact, I believe that has been sent out as well. And if the instructions didn't go out with it about how far it's supposed to be posted from the patient and everything else, we can email that out. But I think that there is an easier solution that perhaps will meet our needs. So there is something called Peak Acuity app. You can see where it's available down here. It was developed by ophthalmologists, first described in publication in JAMA Ophthalmology in 2015, where it was used in Kenya at a patient's home. So not being held by by an ophthalmologist, but by someone, a family member, and compared to a clinic assessment. So this is a type of validation, and it seemed to perform well. That is, the difference was less than 1 line of vision difference. If you recall on the Snellen visual acuity chart, you go from like 20/30, 20/40. So the difference would have been less than 1 line jump. Is that enough for our purposes? It may be. Certainly would be enough in terms of there's, well, I would propose that if there is any difference from what we assessed in clinic, that they should be brought into clinic for a formal visual acuity test. And in fact, I think trying to know, given that this is likely to differ from the clinic-based visual acuity tests, what I could imagine is after you've had your newly diagnosed TB patient come into clinic, get all their tests, have a visual acuity test, use this Peak Acuity app, that you also perform a visual acuity test with Peak Acuity app in clinic so that you can then compare it to the results at home. It is free, and you have different options for scoring it. So you can choose an option for imperial, that is feet and inches, 20/20. You can choose an option for 6 meters, 6 meters, and you can choose this log MAR option. The major downside is that it requires the patient plus 1 person to hold the smartphone. An instructional video is available, and if you don't mind, I'm going to play it right now.
Now I'm going to test your eyes, so if you can just rest your head back against the wall. Now this test uses the letter E and it changes in different directions. So this one's pointing down, so if you could point down, and you'll see I swipe the screen to respond. Excellent, that one's pointing to me. See this one's going that way, so point that way. Now we've got one that's pointing down, you point down. And I'm going to stand over there to test your vision. We'll test this eye first. So if you can cover your left eye, make sure that the eye is covered with the palm so you can't look through the fingers.
Stand 2 to 3 meters away and make sure to hold the phone at eye level. Swipe the phone screen in the same direction as the patient points. Even if their answer is incorrect. If the patient indicates they can't see, then shake the phone to record this. Watch only the patient's responses. There's no need for the examiner to look at the screen, and the phone will vibrate when the test has ended.
This is your score. So you scored 638. Now, this is what things look like for you in the distance, whereas this is what it would be if it were clear. We can also hold the camera up. We can have a look around the room to understand what things are like for you.
So, as you can see here, it presents it in our sort of imperial units for the Snellen. And you can have the patient do each eye, and then they can report back the visual results. Let me see here. So, when, I don't have a screenshot of it now, but when you initially start the test, there'll be a little option up here to change, that you can make changes on. I think it's like the 3 usual horizontal bars. You can just select that and it will give you different options for the output. You would likely want to select the Imperial or 2020 output version. So how do I imagine using this? Well, if you've done it in clinic, the patient will know how to do it. Perhaps even, well, maybe or maybe not that the patient has been accompanied by a family member. You could even provide the patient with a pre-cut string for that 2 to 3 meter distance. And then when they do it at home on a monthly basis, use that string, hold the phone, cover the palm of each, cover each eye with the palm of their hand, and record the results separately for the left and right hand to provide to you as an assessment of the visual acuity. That's it. I'd love to hear anyone's ideas about other methods for assessing visual acuity in the social distancing era.